Hello again to everyone. My name is Rizwan. I'm a doctor. I work in Dublin in the Republic of Ireland. I'm working in an acute medical assessment unit at the moment, and I'm FY2 grade, according to the UK. So I was asked to just give this talk on renal medicine. So I prepared this for you guys. Before I start, I think everyone realizes that clinical nephrology can be quite difficult, and the reason I think everyone, including myself, we find it so difficult is that there's more than anything, there's a lot of tie into your basic sciences, your biochem, your pharmacology, your physiology. But I think clinically speaking, day to day, it's not so important to know every single detail. It's not always so important to know why specifically the mechanism of what something happened or why it happened. Usually it's enough to know that it does happen. For example, the side effect of a medication we prescribe. Keeping that in mind, there are some high yield topics in nephrology that I feel get tested commonly and show up day to day. So we're going to go through them today. And despite my best efforts, I won't be able to cover everything tonight. So just use this talk as a way to kind of recap the major concepts, and we can test ourselves at the end as well. And if you have any questions, then maybe you can keep a note of them and I'll try to get to them at the end. So the talk today, it's going to be roughly just over an hour. Firstly, we'll go through some basic anatomy and physiology. We won't be doing anything too in-depth, but just the clinical aspects and what's relevant to us clinically. Then we'll go through some renal pathology, some diseases, and then we'll go through some clinical cases. There's a couple of things I won't be covering, I feel, because they'll be covered elsewhere. Clinical biochemistry and kidney stones sometimes are covered by the urology doctors, the surgeons. So yeah, I know nephrology isn't always the most enthralling topic, but sure, look, that's what we're here. Let's try and get through it. So just one slide on embryology. Again, only mentioning it because of how it presents with the disease state to us clinically with our patients. So the kidneys, the renal system develops from the mesoderm in embryology. The ureteric bud, as you can see, the thing in yellow here, connects on to the mesonephric, metanephric mesenchyme, and this interaction is what allows the development of the kidneys in the collecting system. And whenever there's a problem with this interaction, that's when you start to get pathology. So if there's an incomplete interaction, you can get kidneys that aren't formed very well, so multicystic dysplastic kidneys. And if there's no interaction for whatever reason, you can get complete agenesis of the kidney. If a single kidney is affected in this state, then the other kidney hypertrophies and compensates. If both kidneys are gone, then you can get something called Potter's sequence, which I'm sure you guys are aware of. In utero, the amniotic fluid is produced by the fetus's kidneys. So if there's no kidneys, there's no amniotic fluid. There's nothing to protect the baby in the womb. So you get this, limb deformities, flat face, and lung hypoplasia as well. Then just a few other things that tie into embryology. I'll go through step by step. So the first one is Wilms tumor. So it's a type of renal cancer that commonly affects children, the most common type that you see in young children. And it's relevant because the actual tissue that we see that proliferates is that metanephric mesenchyme or blastema that forms in the embryological tissue. You see that in young children, which obviously you shouldn't see. Then there is the ureteropelvic junction obstruction. So commonly you see that at the junction of the pelvis and the ureter. You can get stricturing in utero, and this can cause hydronephrosis, basically due to malformation of these ducts, and they can cause pathology. You can have duplex collecting systems. So say if the ureteric bud, when it comes into the kidney, it bifurcates, you can end up with two ureters. And it's important because it can result in the next condition called vesicoureteral reflux. So it's really common in children. It can cause recurrent UTIs. It can be primary with no specific cause, or secondary due to some other pathology or anatomy. You can have remnants of the urethral duct. So the urethral duct connects the bladder to the umbilicus in utero. If there's remnants or incomplete obliteration, you can get remnants, and they can cause problems down the line. And then you can get horseshoe kidney as well. So that's just the duplex ureters. That's the urachal remnants, and then this is the horseshoe kidney. So this is when the inferior poles of the kidneys fuse. Why it's relevant is that you may see this or pick this up incidentally on a CT scan and MRI scan, and you worry about wonder about the significance. The thing to keep in note is that it can be present in syndromes, Down syndrome, Turner syndrome, and it can also lead to vesicoureteral reflux as a result of abnormal ureters. So let's get to the anatomy. So our kidneys lie in the retroperitoneum, and the spinal level is usually from the T12 down to L3. The average size is about 10 to 13 centimeters, and that's relevant when you're reading ultrasound reports or any kind of imaging. You should know how big a kidney is meant to be. It's supplied by easily named the renal artery and vein, and it takes a lot of the cardiac output per minute, so about 25%, to try and clear through all that blood. I suppose one anatomical thing to be aware of is the way the left testicular vein drains into the left renal vein. This is important because it results in, less than ideal blood flow at times. It can cause a varicocele on the left side. You guys will remember that the right testicular vein drains directly into the IVC. Then sometimes, I think on clinical exams, on finals, you may get asked to differentiate, or how do you differentiate a spleen versus a palpable kidney on exam. I know I was asked that before, and just a few points to remember: that its location, does it move with respiration, can you get above it, things like that. So for coming in kind of closer, the functional unit of the kidney is the nephron. We have about 1 million of them per kidney. The way they're arranged can result in an outer region called the cortex and an inner region called the medulla, which you can see on the image there. And then the nephron can be further classified into the vascular component and the tubular component. So here's a kind of funny looking drawing, but what you can see there is in the red, that's the arterial supply. So initially comes off as the afferent arterial, with A for arrives into the glomerulus, divides into the glomerulus, which is a tuft of capillaries, and then exits as the efferent arterial. This is all part of the vascular supply. And then the tubular part of the nephron is this Bowman's capsule, which leads around to all the different collecting system and then eventually to the collecting duct. So let's start by looking through the glomerulus, the vascular section first. So this is really where all the business happens in the kidney. It's special in that it's one of the only places in the body where the capillaries don't turn into venules after they've been, the blood flows through them. It exits as another arteriole. And the reason for this is that we have tight control of both arterioles, so we can closely monitor and change how our GFR, affects. Then the reason this is relevant as well clinically is that the effect of drugs on these arterioles. So prostaglandins dilate the afferent arteriole, so increase blood flow to the glomerulus. We all know that NSAIDs can block prostaglandin action and production, and as a result they can cause constriction and reduction in renal blood flow or plasma flow, and this is one of the mechanisms by which giving someone an NSAID may cause a reduction in the renal function. Then you have the exiting arteriole, which is acted upon by angiotensin II. So I'll get onto it, but angiotensin II is a generalized vasoconstrictor, but it preferentially constricts the efferent arteriole first, or more than the afferent arteriole. So if you block it with an ACE inhibitor, you can, the net effect will be a reduction in flow across the glomerulus through reduced pressure. This is especially important if in the clinical scenario you have someone, a middle-aged man, who has hypertension. You don't really work them up. You start them on an ACE inhibitor and they go into renal failure. That can be due to unmasking of a renal artery stenosis. So if the blood flow coming into the glomerulus is already reduced, and then you're increasing the blood flow out, you really drop pressure drastically. And this is how sometimes ACE inhibitors can unmask renal artery stenosis. So what's the function? It filters your plasma into Bowman space as an ultrafiltrate, and these are the things you can see that come out of it. And it stops the filtration of most proteins and your components of your blood, like white blood cells and red blood cells. So pathology happens when any of this is broken down, and what happens then is that you get leakage of proteins, leakage of blood into the urine, and that comes out as proteinuria, hematuria. And importantly, it's hematuria with red blood cell cast, which is different from hematuria, which you may see further down in the urinary tract. I suppose a key site is that whichever part of the glomerulus is affected by disease pathology, that's what ends up determining how the disease presents and whether it's a nephritic or nephrotic pattern. And we'll get into that. So this is what I'm talking about. So here is the actual filtration bed, kind of like the sieve, what filters out everything. Yeah, no problem. So the first step is this endothelium. So if you can see here, the red part is the blood, and then the yellow part is where the urine drains out into the collecting system. So the first barrier is this capillary endothelium. So this is the walls of the capillaries. They're relatively, large holes, fenestrated, so large stuff can get through, but not large enough so that the red blood cells and the white cells and the platelets get through. So that's the first barrier. The next is the basement membrane, which is connective tissue, type 4 collagen, which has a negative charge, and that forms to repel things like albumin, which are also negatively charged. And then the last barrier to defense is your epithelium or your podocytes. Again, they have very small slits, and they work as a physical barrier to stop anything else getting through. And then, like I said, you can get pathology at any one of these three places, and then whatever is affected, that results in either blood or protein or both coming through into the urine, and that's what we can detect. So how do we assess kidney function? It's a good, we talk about pathology, but how do we actually assess when the kidneys are going wrong? It's the glomerular filtration rate is the actual unit we use. Now, if we wanted to measure it perfectly in a kind of, ideal situation or lab situation, you use a chemical called inulin. And inulin is perfect for this because all of it is excreted, and none of it is reabsorbed. All of it is filtered, but none of it is reabsorbed or secreted, which means that whatever goes through the glomerulus, is coming out into the urine. So if you measure the clearance, you can calculate the filtration rate. However, we don't use this in practice. We don't give inulin to everyone we see. We use the closest naturally occurring substance, which is creatinine, and you've probably heard of this. It's a breakdown of muscle metabolism. So it's not as perfect. A small amount of it does get secreted back, so there is some overestimation. But for the clinical work, it's perfect. Again, if we wanted to do it perfectly and by the book, we'd need to get multiple measurements like plasma, urine, things like that. But practically, this is not possible. So we use surrogate equations to try and get an impression of what the creatinine clearance is. So I have a question here. Why don't we use inulin? I suppose that, it would be quite cumbersome. We could give inulin to everyone. I suppose the cost is part of it, but, as part of a renal profile, our body already creates a substance called creatinine. So once something's already there that is almost as good, then we just use whatever is there instead of using inulin. Inulin's only ever used in like physiology and lab kind of experiments. And then the last caveat at the very bottom, it's kind of a asterisk that you may get asked in MCQ that if you want to assess a renal plasma flow and not glomerular filtration rate, you can use this molecule called para-immunohippuric acid, or PAH. So there's a subtle difference between GFR and plasma flow. GFR is whatever gets filtered through the glomerulus, but plasma flow is that plus whatever flows through the capillaries. So there's a minor difference, but just remember PAH. And then I'm sure you've heard of the equations that we use. So this MDRD, but the more commonly used one in practice is the Cockcroft-Gault equation. It's good if you can remember it, but just so you know, everyone has a calculator on their phone that they use day to day. It takes into account the patient's age, their weight, their gender as well. So when we know GFR, what we can go back and say if it's something that affects it, what can affect the GFR and how we function. So there's two main theoretical forces: hydrostatic and oncotic pressures. It's like the same as capillaries anywhere else in the body. Hydrostatic based on how much water and pressure is in the system and opposing the system, and oncotic pressure is the presence of proteins in or outside of the vessel, and these two actions oppose each other. Good thing to remember is that we know that hydrostatic and oncotic pressures can change our GFR, but on a day-to-day, it'd be really impractical if any time our BP drops, we can get up, our GFR drops as well. That would be impractical. So our body's thought of a way to kind of get around this, and it's called autoregulation. So over a range of blood pressures, our glomerular filtration rate remains the same. How does it do this? There's a couple of ways. So the arteries themselves, respond to their own stretch and either constrict or dilate. And then also the more important one is called the tubulo-glomerular feedback. So I'll show you in a second. I had a picture of it, but I see it's covered the juxtaglomerular apparatus. So this is a very specialized kind of endocrine area in the kidney, in the nephron, which responds to certain stimuli and causes subsequent effect. So one of that is a response to the detection of sodium chloride in the urine. So if the glomerular filtration rate is reduced, then what you'll have is less urine being produced, less sodium chloride being produced into the urine. This is detected by certain cells, and then what they do is they release either endothelin or bradykinin to try and increase or decrease that blood flow. It's a really sensitive way to make sure that our kidneys are working as they should. So you can see here this graph on the right, you can see that over a wide range, about like 80 to 200, our systolic blood pressure, our GFR is the same. Now, that's not to say it'll work all the time. It can be overwhelmed if there's this, precipitous or significant drop in your blood pressure, and that's when you start to get into trouble with pre-renal failure. So we talked about the vascular system, the glomerulus, the capillaries. Now let's talk about the tubular system, the other part of the nephron. So the ultrafiltrate comes into the Bowman's capsule, which is what you can see here. It's the first part of the tubular system. Now, if you were thinking about this, if someone was thinking about it, they may say that, okay, why can't we just filter everything we need to and keep everything we need to at the glomerulus initially and then just let everything out into the urine? The reason we don't do that is because our current system allows us for increase in control and tight control. So this ultrafiltrate lets go of more than what we'd like to, and then we selectively take back what we need to based on our physiological state at present. And that's done by the tubular system. So at different levels along the nephron, different things get taken back to different amounts. Essentially what that means is that we control this tight homeostasis of water and electrolytes. It's important to note that the formula at the bottom, just conceptually, that if you want to find out the total excretion of any substance, it is how much comes out through the glomerulus, how much is filtered, then you minus how much we reabsorb later on, and then add on how much we secrete as well. So that's essentially how you find out how much electrolytes we're clearing out. So again, why is it important to know this clinically? This is clinical teaching, because there are some diseases that affect specific different parts of the nephron, and if you know how the nephron functions, then it helps you understand how the disease presents itself. As well as that, it's a key area for drugs, and they target different receptors along there. Let's go through a few of these things. Now, again, I'm not going to go into the nitty-gritty. I don't think it's relevant, but let's talk about the key things that we should know. So starting with the first part, the proximal tubule. So as I mentioned, when we filter through the glomerulus, that we let go of a lot more than we'd actually like to let go. And then most of it is reabsorbed straight away at this proximal tubule. So 100% of our glucose and amino acids are reabsorbed at this point, and 67% of our water, potassium, bicarb, things like that. Now, by us knowing that 100% of glucose and amino acids are reabsorbed, that should let us know, or we should be thinking that if glucose or amino acids ever show up in the urine, it's usually a pathological state. The caveat to that is in pregnant ladies, you can have glucose and that can be normal, but other than that, it's abnormal. Clinically relevant because of Fanconi syndrome. So this is a disease which results in kind of complete loss of proximal tubular function. It can be congenital or acquired, for example, multiple myeloma or lead poisoning. And it causes exactly the opposite of what the tubule wants to do. So it causes glucose to be excreted in the urine, amino acids, it causes loss of water, hypertension, these type of things, hypokalemia. So if you know what the proximal tubule does, you'll know exactly what happens in Fanconi syndrome. Then acid-base balance as well. This is one of the key things that the kidney does, and a lot of it is done via resorption of bicarbonate. As you know, that acid-base balance is dependent on protons and bicarb mainly in the body. And when we metabolize day to day, our living, our function, that we make a net production of acids. So we need bicarb to buffer that out, and this is done by resorption in the kidney and some of what we make as well. Then coming on to drugs, and there's a couple of drugs that act on the proximal tubule. One of them is carbonic anhydrase inhibitors. So you see this green molecule here. They inhibit that and they cause reduction in the absorption of sodium, so more of it gets excreted, so it acts as a weak diuretic. And then importantly, SGLT2 transporter inhibitors. So these are the new kids on the block, dapagliflozin and things like that. So they're used for heart failure and diabetes both. And the way they act is on this sodium glucose co-transporter in the proximal tubule. When you block that, what you get is more sodium being excreted and more glucose. So it works well for both heart failure and diabetes. Now again, side effects, you can think more glucose in the urine means more infections. And also the significant one is euglycemic DKA. Then coming on to the loop of Henle, again, we don't need to go into the nitty gritty, just big picture stuff. So the main function of the whole loop of Henle is to concentrate urine and reabsorb water. That's what the thin descending limb does, and the ascending limb reabsorbs some of that sodium chloride as well. And it's relevant because loop diuretics act on the ascending limb, the sodium, potassium, 2Cl chloride co-transporter, the loop diuretics, they work here. Then coming on to the distal tubule, again, only big picture stuff. Usually, physiologically, it reabsorbs sodium chloride, and we can stop this by giving people thiazide diuretics. So this results in reduced sodium and chloride in the body and excreted in the urine. And this is also where PTH can act and exert its effect on the kidney. Finally, the collecting duct. So this is where kind of the tubular system ends, and this is where a lot of the action happens. So this is mainly where a lot of the salt and water is reabsorbed into the body if it's needed to be. And in exchange for this, we usually secrete out potassium and hydrogen ions. Now, this is relevant because of the two hormones. One is ADH, or antidiuretic hormone, produced in the posterior pituitary, and it's produced in response to hyperosmolar serum. Basically, when we become dehydrated, essentially, you can think of it in a way, or volume loss. What it does, a net, result of it is that it promotes water retention. So we keep in the sodium, we keep in the water, and it does this via aquaporin channels. The other major one is aldosterone, which acts here. So it's a steroid hormone, and again, it's released in response to angiotensin. So the RAAS system, when our volume gets low, it can be released by high potassium or ACTH. And the net effect, again, like ADH, is to retain that water, to increase our circulating volume. And as a result, it secretes out potassium and hydrogen. This is relevant because of medications like aldosterone antagonists, and also clinical pictures like I'm forgetting the name, but aldosterone, when you have low production of aldosterone, then you can have a similar effects as if you were taking a diuretic. Okay, so one thing to go through now when we're talking about physiology specifically is the functions of the kidney. So we've gone through some of them already, but these 6 ones are kind of basic and easy to remember, and they're good to remember because they're handy later on when we discuss about chronic kidney disease. So I always used to find it difficult to try and remember all the different, causes or all the different, presentations of CKD or the issues. The good way to remember it is to go back to think that what should the kidney do? And then in CKD, it loses all these functions. So usually it's very good at controlling our fluid balance, different electrolytes, acid base. It excretes nitrogenous waste products like urea, creatinine, ammonia, things like that. It produces erythropoietin for red blood cell production. And it kind of, it activates vitamin D and plays a role in calcium regulation. So all of these are functions of the kidney that we should remember. So when we're talking about fluid balance and kind of maintaining effective circulating volume, the responsible system there is the RAAS system. So this is, I've used this picture loads of times before. It's kind of a very good summary, I feel, of what it does. But in essence, what the RAAS system aims to do, or what it aims to do, is to increase your effective circulating volume. It does this when, understandably, when our volume is low, or when it feels the volume to be low or perceives it to be low. It does this by baroreceptors in the afferent arteriole in the juxtaglomerular apparatus, specifically the granular cells. So the first step in this is to release the renin in from the GGA. This then goes on to activate angiotensinogen to angiotensin 1. This then gets acted upon by ACE in the lungs, and it gets converted to the active form of angiotensin 2, which is a real workhorse and causes all these effects. So increases vasoconstriction, releases aldosterone, ADH, all to try and increase the circulating volume. The reason it's important is that clinically we target this system a lot in disease states like heart failure and liver failure, specifically with ACE inhibitors to stop the production of angiotensin 2, for ARBs to stop the receptors at the distal end, and also for the, I say new, it's not new anymore, the heart failure drug sacubitril, along with valsartan and Entresto. So that works by reducing the breakdown of these natriuretic peptides which oppose RAAS. So this is all kind of a goldmine for pharmacological intervention for these disease states. Then let's talk briefly about acid-base. Now, I won't go into detail again because I think clinical biochem could be a whole nother talk, but it's so important in this that I thought I should touch upon it. So like I mentioned before, when we live, when we eat, when we work, our day-to-day, we produce a net amount of acids over bases. So we need something to buffer this out, or else we become too acidic and then we die. So the bicarbonate, the base our body produces bicarbonate. It's the kidney's job to replenish this. So this is the kind of equilibrium equation in the body when it deals with acids and bases. So you can see here's the hydrogen ions, what causes the acidosis. Here's the bicarb. Here's carbon dioxide and H2O. There's an intermediate I've left out here for simplicity. So if you're in a state of acidosis or alkalosis, say acidosis, the hydrogen ions is increased, then you can use this equation to try and understand where the formula will shift and what will go up and what will go down. But if you just want to remember, keep it simple. If there is an acidosis, it has to be either driven by too much CO2, which drives the formula this way, or too little bicarb, which drives it the other way, or drives it back up this way. So alkalosis then is either the exact opposite. So I think to make it simple, if you don't want to go into the actual equation, just remember these two lines for your acid-base balances. It's relevant, obviously, because it's really easy one to ask in the exams. They throw up a table with your ABG, and then they ask you to interpret it. Normally, it's not as simple as a simple acidosis. There's usually two things that are abnormal. The PCO2 and bicarb will both be abnormal. One of them will be the cause and the driver, and one of them will be a compensatory response, and you'll have to find out which is which. So here are the normal values. So again, like we discussed, the body has a buffering system, the respiratory buffering system and the renal buffering system. So as we know, the carbon dioxide, too much of it results in an acidotic state. So the body can get rid of it to induce an alkalosis, or if the body is already in an alkalosis, it can try and retain that CO2 to bring the pH down. Similarly, the kidneys work by excreting potassium, the hydrogen ions, and keeping in bicarb ions, or vice versa. So these are the two buffering systems in the body to maintain a solid pH. The important thing to note, I suppose, is that when you're talking about compensatory changes, they will always move in the same direction as the offending agent. So what I mean by that is that, for example, if there's a respiratory acidosis because of too much CO2, the kidneys will compensate by also increasing the bicarb. So the compensation will always move in the same way if it's just a simple primary disorder. So for example, we see here that someone's pH on an ABG is 7.29, so that's low. So we know that's an acidosis. Now, I know from the previous slide that an acidosis can only be driven either by too much CO2 or too little bicarb. So which is it? So the CO2 is low, so it's not that, so it's too little bicarb. So this is a metabolic acidosis. Now I need to check if there's any compensation. And like I learned here, the compensation goes in the same way. So my CO2 is low, so my bicarb is low, so my CO2 should also be low to compensate. And it is. So then, I would say that this is a metabolic acidosis with some respiratory compensation. Important thing to note when we get onto about mixed disorders is that the body is rarely able to completely correct to a normal pH with compensation if there's an ongoing disorder present, acidosis, alkalosis. If you find that the patient's pH is normal, but their PCO2 and their bicarbs are abnormal, then you need to think about a mixed disorder. But for that, if we do find a metabolic acidosis, the next step is your anion gap. So you'll all remember this equation. You can either use this one or the one with potassium or without potassium. I usually use the one without potassium. Just use whatever your med school has taught you, whatever you're used to. Just know that the ranges differ slightly. It's important to calculate because then if it's a high anion gap metabolic acidosis, HAGMA, then it has specific causes. If it's non-anion gap, then there's more specific causes for that. And then I was talking about mixed disorders. So this is something that always I found tricky. I still find tricky because it's not so intuitive. Like I said, if there is a normal pH and abnormal, electrolytes, then you can think of it. Or sometimes if there's a metabolic disorder without respiratory response, which you would expect, then you can start to think of mixed disorders. But overall, I think, it would be very unfair to give you guys these questions. The only one that I can think of that you should probably keep in mind is aspirin overdose, because it's so common. That can cause a mixed disorder by an early respiratory alkalosis, because the acid stimulates your medulla, so you hyperventilate, and then eventually the metabolic acidosis from the actual acid of aspirin being mixed in with your blood. The way you specifically detect these mixed disorders is like 4 or 5 different equations you can use. But again, I would say that it's not so relevant here. So just know your basic stuff. Your approach should be to check for the pH to determine what it is, then go to see what is the driver, then check for compensation, and if you need, check for the anion gap. So that's acid base. And here are the different causes. So like I mentioned, for your high anion gap in the metabolic, remember your mnemonic mud piles. So I don't even remember anything, but it's methanol, uremia, DKA. So that can also include other acidoses as well, like ketoacidosis due to starvation, things like that. Ethylene glycol, salicylates. You won't be expected to remember everything, but just the major stuff. Then your non-anion gap metabolic acidosis, so things like diarrhea, Addison's disease, that's what I can remember earlier, spironolactone, IV saline, and RTAs. Then for metabolic alkalosis is usually hypokalemia, so it's important to note that potassium and hydrogen ions are inversely related in the body. If there's low potassium in the serum, in the plasma, then your body tries to shift the intracellular potassium out to compensate for that. And the way it does that is it shifts out one potassium for a hydrogen being shifted into a cell. So then low hydrogen in the body, in the serum, causes an alkalosis. So just know that potassium and hydrogen are inversely related. There's certain genetic syndromes that can cause metabolic alkalosis, diuretics, and severe vomiting. And then respiratory acidosis, alkalosis are easy. It's usually due to hyper or hypoventilation, and whichever causes both. So you can see them there. Okay, so let's get on to actual pathology. So what I'm going to cover today in terms of renal diseases is the following. So AKI, nephrotic versus nephritic, UTIs, cystic diseases, cancers, rhabdo, and CKD. So there's 2 aspects to covering kind of any pathology when you're in med school. One of them is what will be relevant on your exams, and one of them will like what's relevant for day to day on the wards and in clinical practice. So the things highlighted in bold is what I feel are kind of clinically relevant. You see them day to day, they're common, they're bread and butter. It's important to know about them. They can present in patients as well on the ward. The other ones are more, I feel, testable on kind of written MCQs, these type of things. So still important to know about, but they're not relevant so much in the patients you see day to day. Of course, different if you're doing a nephrology rotation. So let's go through them anyway. I'm going to start with AKI. That's, I feel like, one of the most relevant things that you should know as students, because of how common it is, how often we see it. So let's start with that. So how do we define an acute kidney injury? So there is a KDIGO classification. So this is a collaboration of nephrologists who come together to provide guidelines and definitions. So this one is really important to know. I'd recommend everyone to learn it. So it's any one of the 3 of those first 3 things. So a rise in your serum creatinine of greater than 0.3 milligrams per deciliter within 48 hours, a rise of greater than 1.5 times your baseline, that is known, or your urine volume to drop less than 0.5 mils per kg per hour for 6 hours. So if you have any one of these 3 things, then you have an AKI by definition. It can be graded on severity, stage 1, 2, 3. That's more relevant in research, and also, sometimes if we want to compare people with AKIs, it's very different. Someone has a mild versus a severe, so it's important prognostically. So how do these patients present with AKIs? It's actually usually incidental, I would say. Even working in the AMAU, we get a lot of referrals from GPs who've done blood tests on someone who hasn't had blood tests in the last 5 or 10 years or however long, and they find that they're urea and creatinine are through the roof, and they refer them in as, query AKI or CKD. So the big question then is, how do you actually tell if it's acute or chronic? The easiest and simple ways, if they present in an inpatient, just have a look through on their system, what has their creatinine trend been? If it's come up according to any of those criteria, then you can say AKI. This is more difficult if it's an outpatient. If you can, ring the GP and try and find a recent blood test. If not, then you have to go off other things. So one is to check the creatinine trajectory. How is it going up or down or staying the same? Other things are symptoms. So if someone presents with an acute renal injury, AKI, they may have, recent onset lethargy, dehydration, shortness of breath, and nausea and vomiting. Autouria is pretty sensitive, and they may present with confusion, seizures, coma. However, if someone has had CKD for years and years, they're unlikely to have those things. More likely, peripheral neuropathy, nocturia, itchiness, these type of things are associated with chronic diseases. Anemia can tell, now put an asterisk next to it, because a normocytic anemia favors a diagnosis of a chronic issue because of lack of EPO production. But anemia can be caused by so many different things that I wouldn't pay too much attention to it. What is quite useful is an ultrasound scan of your kidneys. If someone has chronic kidney disease, then the kidneys can appear small, shrunken, increased cortical thickness. These type of things favor a chronic, whereas someone, who have maybe normal looking kidneys or hydronephrosis, then you're thinking something more acute. So this is your kind of approach to someone who presents with a kidney injury. Then our causes. So this is really high yield. I would say that, it's a really good way to categorize your causes of AKI into pre-renal, intrinsic renal, and post-renal. It's a good way to give yourself a second in the exam if you ever get asked, to categorize in your head and take a second and have a system to go ahead with. So pre-renal usually means that there is either a true or an effective volume depletion. What happens is that there's a lack of blood flow to the glomerulus, to the kidneys, and that causes a reduction in GFR that results in less urea creatinine being filtered and going up in the blood, and that's what you detect. Now, remember, this is when the compensatory mechanisms maybe are overwhelmed with significant hemorrhage or GI losses in true or ineffective volume depletion, so in cardiorenal or hepatorenal syndrome. And this may sound a bit confusing because in your heart failure patients and liver patients, they're actually often overloaded with fluid, and you're thinking, how is this happening? It's because the fluid is all in the wrong space. It's all in the interstitial fluid when we really need it in the intravascular. What happens then is that your kidneys think in the juxtaglomerular apparatus, oh, I'm not getting enough blood flow, I need more. They activate the RAAS system, and it's a vicious cycle. Then the intrinsic renal, these are ones that are harder to identify. So they include tubular, and the most common one is ATN, acute tubular necrosis, and it's one that you should know about. It's about 50% of the cases for intrinsic renal. It is either caused by an ischemia. So the confusing thing here is someone has a lack of blood flow due to ischemia or hemorrhage, then they may initially present with a pre-renal, but then also if it was a pure pre-renal volume depletion, you may expect them to get better after a few days after you give them IV fluids. If it's not getting better, their urea creatinine staying raised for days to weeks, then you can maybe say that, oh, they had an ATN injury on top of that. So it can be caused by ischemia or toxins. So toxins can be either endogenous or exogenous. Endogenous toxins include things we make ourselves, like myoglobin in rhabdomyolysis or light chain proteins in multiple myeloma. And exogenous toxins, I'm sure you're all aware of, NSAIDs, aminoglycoside drugs, radio opaque dye, these type of things. The way to differentiate this is when you look at urine microscopy, you see these granular casts, and often, like I said, these can take weeks to resolve. Then you have interstitial causes of intrinsic renal. So what we're talking about here is acute interstitial nephritis. So this is a hypersensitive reaction almost always to drugs. Rarely it can be due to infections. But the common culprits are antibiotics, NSAIDs, PPIs, allopurinol. What you get here is you get white cells in the urine in the absence of an infection because this is a hypersensitive reaction. And you get these classic white blood cell casts, which are only seen in interstitial nephritis or pyelonephritis if there is an infection going on. You also see eosinophils in the urine. Other causes include RPGN, we'll get onto that later, and then vascular issues as well. And then post-renal is the last one, and that's due to obstruction at any point in the outflow tract. So that can be as close as the calculi, or in the ureteric pelvis if there's a tumor or stone, and it can go down all the way to the prostate if there's a large prostate, and it causes significant backup of the fluid. So all these can cause AKI. So how do you investigate someone? So someone's presented to you like this, they kind of maybe presented by the GP or whatever. How do you actually work them up? Actually, the main thing that you find out, 90% of your diagnoses are by history and exam. I know everyone says that it's boring, but it actually is true in nephrology a lot of the time. Because if you go back here, if someone's been bleeding out of anywhere, they'll tell you, enough to cause a renal issue, or if they have enough GI losses. If someone hasn't been able to pass a urine, they'll tell you, right? If someone's recently taken a new drug, they'll tell you. If someone, has heart failure, has a liver failure, they'll tell you. You can see it on exam with overload, and pre-renal on exams will be dry. So these type of things, a lot of the stuff you can differentiate here alone. Then if you can't find out still, then you can go around digging. Usually, urinalysis and microscopy is always a good bet. It tells you if there's CAS, it differentiates a lot of things. Blood you can request if you're thinking about intrinsic renal, then you're digging around looking for virology, connective tissue disorders, Goodpaster syndrome, rheumatoid, all these different things that can be related to inflammation. And ultrasound kidneys, like you mentioned, and then a kidney biopsy. So kidney biopsy is really gold standard. And when we have the biopsy sample, we use 3 methods to look at it under a microscope. So the first one is light microscopy, so lowest resolution. Then we have immunofluorescence, and then we have high resolution, which is electron microscopy. So the question may be, if someone's come with an AKI, so I'm sure you're all aware, renal biopsy isn't something to do lightly. You're going into a hypervascular structure. You want to make sure you want to get the biopsy. You're not just going to biopsy everyone. So who do we biopsy? Usually patients where it's been a while, we haven't found a diagnosis and their symptoms are ongoing. If we feel that we get to a certain or specific diagnosis, that we could treat them for that, and that we're not treating them for now. And to, again, establish chronicity. Is this an acute or is this a chronic thing? If we do a biopsy, we find out something with this chronic changes, then it's unlikely to benefit from certain treatments. And again, one thing to keep in mind is that these patients are at increased risk of any sort of procedure as it is because of their platelet dysfunction. So sometimes, rarely, you give desmopressin. It's not really evidence-based, but sometimes it's given. And we also may sometimes do dialysis to, improve the general body function before we do a biopsy, if it's needed. Then the management of an AKI. So this is also really important. Usually a good place to start if it's a severe AKI is to put in a catheter, because you want to measure the urine output and closely to make sure it's not dropping and it's improving the way it should. Then you can go step by step. And again, I know it's a long enough list, but it's really important. I think if you are able to mention these things in your exam, they'll be quite impressed. So one thing is to treat a reversible cause. As I mentioned, in your history and exam, you'll be able to find, usually speaking, the offending agent. If it's dehydration, you're going to lash some fluids into them. If it's a large prostate that you haven't passed urine in 2 days, you're going to put in a catheter. If it's, some sort of drug that you feel may have caused it, you're going to stop that, okay? Then what you're going to do is maintain euvolemia. You're going to diurese them if you need to. You're going to give them IV fluids if they need to. Often with an AKI, they can get electrolyte abnormalities like hyperkalemia, so you want to treat that if it's there. And if the patient is sick, which sometimes they can be, with really high creatinines, then you want to involve the renal or critical team early. Example, if you're heading towards dialysis. You want to avoid further nephrotoxins, which sounds obvious, but often in a hospital setting, sometimes I know myself, we order or request scans without thinking about the patient's, baseline. If you order a CT tap or CT abdomen with contrast, a patient with a severe AKI can't get that, or shouldn't. Then you're going to review their med list. You're going to hold whatever you can that's not essential, and if everything's essential, you're going to make sure that it's dose adjusted if it needs to be. You're going to put them on a modified renal diet, and then constantly assess the need for dialysis. And if you do that, you'll hopefully fix anyone with an AKI. Then another really high yield slide, your indications for hemodialysis in AKI. So if someone presents to you with an AKI, and it's severe enough, what are the cutoffs that's going to make you go towards the decision of dialysis? Because again, it's not a light decision. It's sorts of complications. You need a central line, a VAS cath, things like this. So AEIOU is a classic way to remember it. So A for acidosis. So usually if it's refractory, if it's not responding, or if it's very severe, less than 7.1. So E is your electrolytes, mostly hyperkalemia, or that's refractory again, not just any hyperkalemia. I is intoxicant, so like an overdose that can be dialysable. That's dialysable. O is overload, but specifically that's refractory, and usually it's in the setting of oligo or anuria. And the reason is that if you think about the way your diuretics work, they work in the nephron when urine is being made. So if there's no urine being made, it won't do anything for you. So usually it's in that state. And then finally, if someone has significant uremia with complications like confusion, encephalopathy, pericarditis. So this is a must to remember. It's pass-fail stuff, I think. This is a handy slide I've left on for later for your reference. It really summarizes things well, I think. The number 1 is your pre-renal, 8 is your post-renal, everything else is your intrinsic renal. It's just a good one to look over before an exam or something. Okay, so we talked about AKI. Let's talk about glomerular diseases. So we're getting on to the nephrotic and nephritic syndromes here. So just before we dive into it, something to conceptualize. I always hated this because I think it's a terrible way to classify stuff, or not an ideal way. Know that glomerular diseases or pathology that affects the glomerulus can present in a whole spectrum of ways. Usually, because we know what the function of the glomerulus is, it either ends up in hematuria or proteinuria or both to some extent. Now, we can classify them, for example, like glomerular disease into primary renal diseases or secondary diseases, but the way that we're kind of taught and expected to know it is the nephritic versus nephrotic way of classifying. This is just a way of grouping up these glomerular diseases to try and fit them into boxes, which don't always fit, but let's just go with it. So they're differentiated by, histologically by where they affect the glomerulus, and clinically by what syndrome of symptoms ends up presenting before you with hematuria, proteinuria, and their symptoms. There's 2 main investigations that help you differentiate between nephritic and nephrotic, and also between the subtypes. Number 1 is your microscopy, looking at different casts that are present. The urinalysis, how much protein, how little protein is being excreted, and hematuria. And the final one is, like I mentioned before, your kidney biopsy and the different ways to look at the cells. So this is kind of an overview. So there's nephritic syndrome on one side, nephrotic on the other, and there is an overlap. And even, sometimes what's tricky is that in nephrotic syndrome, you may still get a bit of hematuria, which you wouldn't expect. So there's a huge overlap, but just, this is something for your reference. So we'll start with nephritic. So nephritic syndrome, conceptually, is something that a disease process that damages the entire glomerulus, the entire kidney. So what that causes is reduced GFR. That's kind of the main pathophysiology and results in other things. So the filtration barrier to blood cells and both proteins is lost because of the vast destruction that's going on, but you don't get massive proteinuria because your GFR is so low, because so little of your plasma is getting in due to impairment of the function that you're not able to lose as much protein. So what you get here is hematuria, again with the asterisk that where the red blood cell cast. This is a huge thing to remember, and the protein in urine, but less than nephrotic syndrome. So they present with dark urine because of hematuria, swelling, edema, fatigue, and proteinuria less than 3.5 grams per day. So the 3.5 grams refers to a 24-hour urine collection. Again, that's a bit cumbersome, hard to do. So what we often do is we call this spot urine test, a protein to creatinine ratio. And this is a good surrogate marker for total protein lost. If it's less than 300, it's subnephrotic. If it's over 300, it is nephrotic range proteinuria. What are the causes? There's 4 here that we'll go into: the PSGN, IgA nephropathy, RPGN, and also Alport syndrome. So here is kind of what the pathophysiology of nephritic syndrome, another good summary slide for you to go into. But what's happening is, you're getting a reduction in GFR after this inflammation. This causes, on the left, hematuria, blood cells to excrete onto the urine, and on the right, the proteinuria. Again, the proteinuria is massive because of the reduced GFR. The protein being lost in the urine can cause edema. But what can also cause edema in these patients is that you get hypertension. So that's very important because of the sequestration of the fluid that you're not filtering out. This can cause edema as well. You get oliguria in these patients, and you get an azotemia. So let's talk about PSGN, so post-strep glomerulonephritis. Common in children because children get group A strep infections, impetigo, skin infections, or throat infections. Now the key thing, this whole slide to remember of all is that it's a timeline. So you usually get PSGN around 2 to 3 weeks after you've had an infection in a child, okay? So this is important because they want you to know the difference between this and IgA, which happens days after an infection or at the time of the infection. So again, you can do your microscopy. You may not see many things there, but on kidney biopsy, you would see on immunofluorescence, a granular immunofluorescence. We'll see what that looks like in a second. Usually a good prognosis, kids usually recover well, and the treatment is supportive while they have it. So next is IgA nephropathy. So this is one of the most common causes of glomerular nephritis worldwide. And again, the difference is that the presentation is that you get the hematuria similar as before, but only days after an infection. The pathophysiology here is that you have an overactive immune system. You're producing too much IgA, immunoglobulins, and they end up depositing in the kidney as immune complexes in a granular way. You can see here. Again, this is very common, and the prognosis is that patients usually gradually have worsening of their kidney function, and half of them end up with end-stage renal disease. Let's talk about RPGN. So this is a really severe form of glomerular nephritis and a nephritic syndrome. As in the name, it's rapidly progressive. Important thing to know about here, big picture stuff, is that there's 3 types that you'll have to know on exam. And the way that these 3 types are differentiated, why there is 3 types, is how they appear on immunofluorescence. So the first type comes in a linear form. So you can see here really clean lines all along the glomerulus. The second type is granular. So I'll just show you again. This is granular and this is linear. And the last type is pauci-immune. So pauci means a paucity of immune complexes. So you have nothing on immunofluorescence. Type 1 is due to Goodpasture syndrome. So clinically you'll have a hemoptysis on hematuria. Type 2 can be due to different things, like we talked about. IgA can progress to this. You can have even PSGN and SLE, lupus. Lupus, just a quick note, can cause almost any form of kidney disease, nephritic, nephrotic, any form. Lupus can cause it. And then your last one, group 3, the pauci-immune, they're your ANCA RPGN, so they'll be positive for either C-ANCA or P-ANCA. And you treat these people with steroids, and immunosuppression if need be, because of how severe this is. So as a rule of thumb for nephritic and nephrotic, most treatment is supportive unless it's severe enough that you try immunosuppression or that it responds well to steroids, like we'll get onto in minimal change. The last one is Alport syndrome. You don't need to know too much about it, just that it's an X-linked disorder with type 4 collagen. We know that type 4 collagen makes up our whole basement membrane. So when you have dysfunction here, you get this nephritic type syndrome. But then also the classic triad is that there's type 4 collagen in your eyes and ears. So you have pathology there as well. And of course, males, because it's X-linked. So again, this is a summary of nephritic syndrome. Just keep this in mind and go back to it for your reference. It's a nice summary. Then let's talk about nephrotic. So the pathophysiology here is that it's not complete destruction. Where you're losing is a barrier to protein. So usually the podocytes. So what happens here is that you have massive proteinuria because your glomerular filtration rate isn't affected. So you're still getting loads of blood coming in, but it's not able to retain the protein. So all the protein gets leaks out, and you have high reading on a dipstick, more than 3.5 grams per day, or a spot urine of greater than 300 PCR. Presentation is a frothy urine as opposed to a dark urine because there's not much hematuria or no hematuria. You get more significant edema because of the loss of protein, and then you can get lethargy as well. So this proteinuria, this loss of protein, is what triggers the cascade of pathology in nephrotic syndrome. So this is another summary slide that I find really useful. So it all starts with the reduced protein, and it causes all the different effects we see later on. So reduced protein, reduced albumin, results in that reduced oncotic pressure. So your vessels can no longer hold the fluid within them, so they'll end up leaking fluid everywhere into your tissues, and you get edema. This can also be worsened by the RAAS system and the perceived reduction in your circulating volume we spoke about before. Because the low albumin, your liver is like, oh wait, I better make more albumin. And while it does that, it can't really selectively make albumin. It makes everything together. So you get loads of lipids being produced from the liver as well, and you get hyperlipidemia. And these can come out in the microscopy as fatty casts or oval fat bodies. That's important. The protein you lose is really specific at times. You can have lose your antithrombin 3 as well, which is a key factor in coagulation. So you get anticoagulation, so you get thrombosis or hypercoagulability. And then you can release immunoglobulins as well, so you can be predisposed to infection. So again, it takes a second to know, but we'll come back to it, and it's a good summary slide. So here are the causes of nephrotic syndromes. A couple more, but we'll fly through them and only go through what's really relevant. So a very common one is minimal change disease, and it's commonly seen in children. The reason it's called minimal change disease is because on light microscopy you don't really see anything, and you don't see anything on immunofluorescence as well. It's only when you get down to the detail of electron microscopy that you start to see this effacement of the podocytes. So you see in the top image that there's tall, regular-looking podocytes on the epithelium. On the bottom image, you see they're all sloughed off and flat. So this causes release of the proteins and the massive proteinuria. The good thing about this disease is that it's really steroid responsive, and that it has a favorable prognosis. Usually patients do really well after this. And usually in terms of the pathophysiology, what causes it, it's not 100% clear, but it's thought to be a cytokine storm after something like a viral infection, allergic reaction, these type of things. So it makes sense why steroids work for something like that. The other one is FSGS. So think of it like, you can kind of link these two together in terms of pathophysiology. It's like minimal change, but maybe more worse. You can think of it like that, because it also ends up with effacements of your podocytes because of these sclerotic lesions. So the name is focal, meaning that only some of the glomeruli are actually involved. As you can see in the image, some of it is healthy. Segmental because, focal because some of the glomeruli are found in the kidney. Segmental because only parts of the glomeruli are involved. And sclerosis because you see these kind of collagen deposits causing sclerosis. It can be primary, unknown cause, or secondary due to certain HIV, sickle cell, heroin. Immunofluorescence is usually negative, but sometimes can be positive for IgM. And the prognosis is worse than minimal change. Another common one is membranous nephropathy. So membranous, just think about it in the name again. What it results in is thickening of the glomerular basement membrane, and you can see that on a light microscopy biopsy. So it's membranous, but not hypercellular, so it's not proliferative, and that's important to differentiate. Again, it can be idiopathic or secondary. The important thing to know in this one is that if it's idiopathic, you'll expect to see autoantibodies against this phospholipase A2 receptor, which is something they may ask you in MCQ. Prognosis, good in children, and rule of thirds in adults means a third will get better, a third will stay the same, and a third will progress on to end-stage renal disease. And treatment, again, like I mentioned, for most of these glomerular diseases is supportive. But if you're high risk, if it's severe, if you're losing a lot of protein, you can try and throw some immunosuppressives at it. So remember, the last one was membranous. This is membranoproliferative, so you get thickening of the membrane and also proliferation of cells. You get hypercellularity. This is a really tricky one because it can cause both nephrotic and nephritic. What can't, to be honest. Nothing high yield from here, except to know that Hep B and Hep C can be associated with type 1. Then the last two of nephropathy, I suppose, are kind of higher yield, is that diabetic nephropathy. Reason is because diabetes is becoming so common in the Western world. What happens here is that the glycosylation of the basement membranes, as well as hypertensive injury, causes progressive proteinuria over time. So usually this is picked up early as microalbuminuria. If you ever go to a diabetic clinic, you'll know they test for this to try and predict it coming on. And it can eventually get so bad that you lose enough protein to go into nephrotic range proteinuria. The other systemic disease is amyloidosis. So if you see on the chart on the right, there's two types, AL and AA amyloid. Either one of these can result in kidney dysfunction, and usually because the kidney filters everything out, is one of the first and most common organs to get involved here. The key thing to remember is that if you biopsy them, you'll see these apple green birefringence and Congo red staining. If any of you did STEP, you'll remember that. Again, this is just a summary slide of nephrotic. Always go back to a summary slide like this to remember why these syndromes present as they do. So what does it all mean in the end of it? What is the point of learning nephritic, nephrotic? What's the whole point? I suppose clinically, not so much. If someone comes to you with anything that looks like a glomerulonephritis, to be honest, you're probably going to refer them to some, nephrologist or renal specialist. But I suppose in terms of exams and finals, unfortunately, they expect you to know the difference in patients in MCQs and also the subtypes. So just make sure you know the major differences. Let's cover UTIs quickly because, again, they're really common. So important differentiation factor is that what's the difference between bacteria being present in urine versus a UTI? Because often what you'll see, and what's really common, is that we as doctors, we treat bacteria being there too often. So bacteriuria means that there is bacteria in the urine detected by urine culture. UTIs when you have that as well as symptoms. So often who can get bacteria? Often elderly patients who live in nursing homes. Sometimes people who have been catheterized recently or are currently catheterized, these type of things. So you only treat if there's symptoms alongside as well, because the evidence points that way. So how do we get urinary tract infections? It's almost always via an ascending pathway. We have flora on our skin and around the urethra, and this comes up and affects either bladder or kidneys. And the common pathogens, most commonly by far, is E. coli, and then less common as you go on. Important thing to know is a complicated versus an uncomplicated UTI. You may have heard this being thrown around before. Basically, uncomplicated is something simple, usually a female who's, as you can see, not pregnant, who is otherwise healthy, just as a one-off UTI, and they have no other pathology. It becomes complicated and if any man has a UTI, if anyone who's pregnant, if there's any sort of abnormality within the anatomy or function of the urinary tract, if anyone has a catheter, if anyone has some sort of immunocompromise. So the reason it's important to know if it's something's complicated is because you treat them differently. You treat them, with more stronger antibiotics. So how do they present someone with a UTI? It's usually everyone would know this, but it's dysuria. If it's only cystitis within the bladder, it's dysuria, frequency, urgency, these type of things. Often these patients are systemically well. It hasn't spread anywhere. They even have normal white cell counts. If it spreads up to the kidney, you can get in trouble. That's when you start to get fevers, flank tenderness. You start to see these white cell casts and tenderness around the costovertebral angle. And this can be serious because it can lead to sepsis as well. So who gets urinary tract infections? Unfortunately, females, just because of anatomy, those who are sexually active, someone who had a urinary catheter inserted, someone with diabetes, pregnancy, someone like I mentioned at the start with a ureteral reflux, or someone with urinary obstruction. Anything which basically promotes or allows for the ascending of the bacteria up through the tract. Again, diagnosis we know is with bacteria. You often screen with the urine dip and confirm with the culture and microscopy and then sensitivity. And then the treatment. Who do you treat? How do you treat them? There's only 2 times you ever treat anyone with asymptomatic bacteria. Usually, as a rule of thumb, know that you usually don't treat it, but the 2 caveats are pregnant patients, because there's an increased risk of progressing to pyelonephritis, and also people undergoing urological procedures like a TURP procedure, because the bacteria can spread in the urine. If it's uncomplicated, you usually treat with a short course of oral antibiotics. If it's complicated or you have pyelonephritis, then you usually need a longer course or IV antibiotics, and sometimes we admit patients for that. I'll try and speed it up here. Cystic kidney diseases. There's loads of different diseases present. The main one that you need to know about, because of its prevalence, is autosomal dominant polycystic kidney disease. For these patients, it's usually picked up later on in life, in their 30s and 40s. The reason is that when they're born, the cysts are microscopic and they're not detected. The kidneys appear normal, but as they grow, as they get older, these cysts grow in size and cause problems like hypertension and impaired renal function. Then you do an abdominal exam and you start to feel these masses, and an ultrasound you can see these big, cystic kidneys. How you'll to know is the associations, so that you can get subarach hemorrhages because of aneurysms, cysts in the liver, mitral valve prolapse. Treatment for these patients is supportive, and then eventually, if they need renal transplant. Here are the other ones for your reference. You can look at them if you want to. Okay, let's fly through the cancers. Again, I say it's not that high yield, but then again, I think it was myself or my friend got a renal cancer as our final case medical exam, so it can come up. So it's important to know 1 or 2 things about it in case you're put on the spot. So they can either arise from the kidney or the ureter and bladder. So let's talk about renal cancers. The first one and most common by far is renal cell carcinoma. If you look at the biopsy on the right, you can see on the left side, this is normal looking glomeruli, normal interstitium. You look on the right, these big, kind of fatty looking clear cells. So this is the most common subtype, which is clear cell carcinoma. It's a subtype of renal cell. Who gets this type of cancer? Males, people who are a bit older, 50 to 70, smoking is a big risk factor, obesity, and some syndromes like von Hippel-Lindau. The classic triad that they talk about is hematuria, a palpable mass, and flank pain, but it's almost never actually those 3 triads, and often patients present late because of insidious onset. Important thing to know about this is that it can often present like the lung with a paraneoplastic syndrome because of all the endocrine function of the kidney. So polycythemia due to EPO, hypertension because of Renal Cushing syndrome. Treatment for renal cell carcinoma is most favorably surgical resection if you can get away with it. If it's early stage 1, maybe sometimes stage 3, immunotherapy works well for this type of cancer, usually poor response to chemo or radiotherapy. The other renal cancers, which are much less common, are Willem's tumor and renal angiomyolipoma. So I'm talking about primary cancers here. Of course, you can get secondary cancers like Mets or lymphomas, but we're strictly talking about primaries here. For Willem's tumor, we spoke about it already. It's due to metanephric blastema due to this, genetic mutation associated with the syndrome called Wagner. Renal angiomyolipoma, kind of blood vessel, smooth muscle associated with tuberous sclerosis. But the main one by far to remember is the renal cell carcinoma. You may even see it on the ward sometimes. Then the kind of ureteric or bladder cancers, by far and away the most common is your transitional cell carcinoma. This is the most abundant lining of the urinary tract. It's often multifocal, and it's a concept called field cancerization. So what that means, you often see it in the ureters or sometimes in nasopharyngeal and head and neck cancers, where either due to smoke or some sort of risk factors, you get this what we call cancerization or effect of all the epithelium, damage of all the epithelium. You can get multiple primary cancers in this case. So risk factors, a huge risk factor is smoking. It's one of the main risk factors we see in this. And then less commonly occupational exposures and cyclophosphamide. You should really be, alarm bells should be ringing if anyone presents to you with painless, visible hematuria. That you should 100% want to rule out anything like a cancer in the urinary tract. Treatment as you would surgery, radiation, chemo. Squamous cell is much less common. You need chronic inflammation to be able to develop these squamous cells, and you either see that from recurrent stones or infection, or the classic MCQ, with schistosoma, hematobium infection, which can be seen in Africa, Middle East, kind of Egypt area. And then adenocarcinoma is incredibly rare and only arises from the urachal remnant because that's lined by these cells. MCQ question. Okay, second last thing, rhabdomyolysis. I mention it again because we do see it. It's a syndrome caused by muscle necrosis. So your muscle breaks down, releases all these things into the plasma, which causes essentially kidney injury. It can be caused by severe exercise, when you're dehydrated, a crush injury or a fall, or certain drugs. The patients present either with the fall, with whatever the trauma, or muscle pain, weakness, dark urine. Someone, for example, is taking a statin. You do a CK, it's through the roof, and the urine dip is positive for red cells. But note that the urine dip is testing for heme, so it's thinking that they're red cells, but there's not actually any red cells there, usually speaking. The way to treat is supportive, give them IV fluids, treat whatever abnormalities there, and sometimes you do need to dialyze these patients if it's severe. And then the last one is CKD, so we're almost there. So again, really quite common because of the amount of patients we see with it. Diabetes is on the rise, and as a surrogate, CKD will be on the rise as well. So there's different stages, but what it does mean is that you have this permanently impaired renal function, which eventually does progress over time. It starts as a GFR of 1, stage 1, all the way down to stage 5, which is classified as end stage. And these patients often need to go on renal replacement therapy, and that can be done as hemodialysis if someone has either a permanent catheter or a fistula. It can be peritoneal dialysis, or it can be by an actual renal transplant. Again, remember I mentioned earlier on that the symptoms of CKD can be linked to the actual function of the kidney. So let's go through them. So if you're not producing EPO, then you can get enormocytic anemia. The vitamin D and calcium dysregulation can result in a thing called renal osteodystrophy, increased risk of fractures, and secondary hyperparathyroidism. Impaired excretion of waste results in this uremia or azotemia, and it causes symptoms as well. Of course, impaired acid-base regulation causes acidosis, and also the major one is that your electrolyte and water dysregulation results in a whole host of things, specifically hyperkalemia, edema, and hypertension. So we take a breather. That was a lot, and we went through a good few things there. So we'll finish off with just going through a couple questions, just to consolidate our knowledge. And if you guys have any questions, you can let them know. Write them down in the chat. I'll try and answer them if I can. Okay, we're still going strong here. Okay, let's go through them. So, question 1. So I'm going to put up the poll in a second so you guys can respond, but we'll read it out for you. So there's a 19-year-old male with long-standing type 1 diabetes. He's come into the emergency department, he's unconscious. So you can't go do much with a history, but you do a blood gas and some bloods, and this is what comes back. So sodium of 160, hyperkalemia, really high urea, high glucose. You can see it there. PO2 seems to be okay, but there are acidotic, so it's 7.1. But my question is, what is the anion gap? So let me start the polling. I believe this should work. Maybe let me know if you guys see this up. So you can calculate it, and I would recommend to use the equation without the potassium. So if you want to take your time there. Unfortunately, I think this might have covered the screen for everyone, but sure, look. Also, if you guys would be able to message in the chat just to see what year you're in. I actually don't know what the spread is, so it'd be good to know. Okay, a few people have answered already. Okay, we'll move on. I think everyone answered it right. So 66. It's a pretty rip-roaring anion gap if you ask me, but let's go through it. So first of all, can you guys work out what the acid-base disorder is here? So remember, the first thing is to look at the pH. So it's 7.1, so I know it's acidotic, and I know that this can only be driven by too much CO2 or too little bicarb. So the CO2 is low, so it can't be that as a bicarb low in the boots. So it's definitely a metabolic acidosis. Is there respiratory compensation? The PCO2 should go in the same way. So if this is low, that should be low. It is. So there is compensation. And the next part would be to measure your anion gap, which we have, and we know that it is very high. So if we use that formula 66, which is greater than 12, then we go on to our different causes for anion gap. Metabolic acidosis by C9 has put in. Thank you for that. Given the clinical scenario, diabetes, high glucose, we're looking at a DKA here. And treatment, I'm sure you guys know, is your IV fluids and your compensation of insulin. Usually DKAs respond pretty well, but as you can see that we're considering dialysis in this patient because of how low their pH is and how high their potassium is. But let's try and treat them first before we jump the gun. That's good. Okay. So I'll try and read this out. It's a bit small maybe, but so question 2. So 17-year-old male presents to the clinic with gross hematuria or visible hematuria. He is currently suffering from a respiratory tract infection. Apparently he had a previous episode of hematuria some 2 years earlier, which was put down by the GP to a UTI. Examination of notes from previous ED attendance after a rugby game revealed that microscopic hematuria on urine testing. So on exam, his blood pressure is fine. Physical examination is unremarkable. So let me look at his bloods. So I'll let you guys go through that, and then the question is, which is the most likely diagnosis? So what I'll do is I'll launch the second poll, and you can take your time reading through it. So if we look through the bloods, we can see that the hemoglobin is mildly low, nothing too crazy. The white cells are normal, the platelets are fine, the sodium is fine, the potassium is fine, creatinine is okay. So bloods are fine. All we're seeing is a little bit of blood and protein in the urine. C3 is normal, and serum IgA is slight increase. So yeah, you guys have done great. It's IgA nephropathy. I think this gives it away a little bit. You probably would have got the diagnosis without that as well. But I suppose the big question here, was it a post-strep glomerulonephritis versus an IgA? We know it's not post-strep because he's still currently suffering from it. Post-strep, you'd expect him to get better, and then all of a sudden him to get this 2 to 3 weeks later. And often, like I said, post-PSGN, you may expect to see some renal impairment as well with that. Not if it's a mild form. Like I said, lupus nephritis can present as anything. Like if lupus is the option, it's almost always could be right. But given the fact that he's young, he has no signs or symptoms of lupus at all, it's unlikely. HSP is important because henoch purpura, it's very closely linked to IgA. It's essentially IgA nephropathy as well as a rash, a purpuric rash. So if this same clinical scenario had this, but with a rash as well, it'd be HSP. And then Alport syndrome, there's no indication of any eye or ear problems. Very good. Next question. So 74-year-old man admitted after a fall, and he spent a period of time on the floor. So he's a long history of illnesses. On examination, he's obese with a blood pressure of 110/75, a pulse of 100, and a temp of 38.5. So he has a fever. Respiratory exam reveals evidence of a right lower lobe consolidation, and he has no kind of trauma. So this is his workup. His ECG shows sinus rhythm, tall T wave, and no ST changes. Chest X-ray confirms what we heard on exam. Hemoglobin's mildly low. White cells are up. I'll let you guys go through the rest. So I'll put up the poll. So question is, what diagnosis best fits with the clinical picture? Yeah, that's perfect. Well done. So if you look through the bloods here, we can see that his white cells are up, probably due to infection going on. Platelets are fine, sodium is fine, potassium is very elevated, 6.7. Urea and creatinine are up, and his CK is through the roof. It's greater than 1,000. The important part here is that his urine dip is positive for blood, very positive, but there's no red cells seen on microscopy, and that's what gives it away in this scenario. So that's classic of a rhabdomyolysis. He has a risk factor for it. He has a fall with a long lie. So being obese, he's laid on his muscles. They've broken down. They've caused this rhabdomyolysis, the myoglobin to cause an AKI to his kidneys as well. So likely as an AKI. We don't know his prior picture. Gram-negative sepsis. I suppose this is maybe alluding to the fact that it a sepsis second to a pyelonephritis or something, but we know it's from the lungs. Unlikely. Acute tubular necrosis, secondary hypertension. His blood pressure seems okay at the moment. Doesn't mean it wasn't before, but given the CK and everything, it fits with rhabdo. Polymyositis, you may also see a really high CK, but you expect to see maybe someone with muscle pain or proximal myopathy for weeks to months, not something like acute like this. An acute myocardial infarction, unlikely given the fact that there's no ST changes on ECG. So same scenario, but different question. I'll put up the next poll. So what do you want to do for this patient's tray? What's your first port of call here? What do you want to do for him? So the options are give him antibiotics, give him IV fluids to resuscitate him, you try and contact the next of kin to find out what happened, give him 10 mils of 10% IV calcium gluconate, or get an MDT falls risk assessment for him. So this, I suppose, isn't strictly renal what I covered, but I think it's again important stuff here. I'll give it another few seconds. Spread of answers this time. Okay, let's go through it. So the answer to the background to this question or answer is that any one of these five, all of these five should be done for this patient. He definitely should get antibiotics. He should get IV fluid resuscitation. We should contact next of kin at some point. We should correct, or temporize the heart to make sure it's not affected by the hyperkalemia. and we should get MTD false assessment. So all of these are right, but the question is, what's your first step in management? So it's kind of, I see there's between two IV fluids or calcium gluconate. So in this scenario, because the patient has hyperkalemia with ECG changes, so essentially what this means is this patient's myocardium is unstable because of the hyperkalemia. Now he definitely does have a rhabdo, and you definitely do need to treat that, but what's going to kill him quicker than the rhabdo is this electrolyte abnormality. It'll cause him to go into arrhythmia and arrest. So in this case, you'd go first with calcium gluconate. Now, so for those who don't know, 10 mils of 10% calcium gluconate is your emergency treatment for hyperkalemia, severe hyperkalemia, or hyperkalemia with ECG changes. It doesn't treat or correct the hyperkalemia, it just stabilizes the myocardium. Your next step is insulin and things like that. But it's kind of reality. I understand it's not realistically, you'd probably give them calcium gluconate in one vein and then fluids in the other vein. So, but initially you should be thinking about calcium gluconate. Then your next step will be IV fluids. This is just what I'm used to, but of course, use whatever hyperkalemia protocol is according to your local trust. Okay, we have a couple more questions. What am I doing for time? Not great. Okay, we'll fire through them quicker this time. So 54-year-old accountant presents to the emergency department with nausea and vomiting, associated lethargy. So history of asthma, well controlled with an inhaler, no other medical history. He doesn't smoke but drinks up to 30 units of alcohol a week, mostly on the weekends, and his obs are as follows. So temperature is 37.2, blood pressure is 108/68, heart rate 92. On exam, he appears to be slightly dehydrated, but there's no other abnormalities, and his blood tests are as follows. The question is, which one of the following of the below symptoms or findings would be most suggestive of an AKI rather than chronic renal failure? So which of these following five would you think would be present in an AKI as opposed to a chronic? So let me just put up the poll. Maybe a little bit more tricky. Let's give it a few seconds. So if we look at his bloods anyway, we can see that his urea is up and his creatinine is up. We know that bloods carried out a year previously was 76, so it's seeming like an AKI, but we don't know for sure, but we'll just treat it as such. Potassium seems to be okay. The question is, which one of these, of the below, would you more likely to see in an AKI or an acute kidney injury as opposed to a chronic? Yeah, good. So oliguria, very good. This is a tricky question. So the rest of them you'd expect to see in chronic. So raised PDH, you'd expect to see secondary hyperparathyroidism after CKD, after the dysregulation of calcium. Peripheral neuropathy could be due to the uremia you see in CKD patients, but the chronic uremia. Nocturia, also just one of those things seen in CKD patients, and small kidneys. Shrunken small kidneys is another thing that we see in chronic patients with CKD. So remember, back to this slide. Oliguria, however, if someone has oliguria, that's a bad sign. It usually means something acute is going on. Someone with a chronic stable kidney disease wouldn't present with low urine output, and something that's worrying. Good, most of you got that right. Question 6, a bit of a theoretical one. You'll hate me for this one. Hold on a second, let's see here. This is a quick one. A bit of physiology. I'll let you read through it. So this is the juxtaglomerular apparatus. Unfortunately, I wasn't able to show it earlier, but you can see here that it's kind of this triangular area between the afferent arteriole and the macula densa. So you can see these are specialized cells which control both water retention and flow through the glomerulus. They also secrete renin, but which cells do that? If you guys get this right, I'll be quite impressed. Yeah, very good. You're all getting it right. Number 4. So going through them, the macula densa is a part, as you can see, of the distal tubule. You see these dark yellow cells. It's not the arteriole. Renin is not secreted at the macula densa. It's secreted by these granular juxtaglomerular cells that you see back again around the afferent arteriole. Is renin secreted in response to raised sodium level at the macula densa? So no. So raised sodium level at macula densa causes change in the arteriole, so cause increase in blood flow to the kidney. What does cause renin release is a fall in pressure in the receptors in the afferent arteriole. Very good. That was a tough one. Okay, so I think there's two more. So actually, I think in the interest of time, I've already taken about an hour and a half of you guys' time. I'll just fly through these myself. So for this one, a 79-year-old man is admitted to hospital feeling generally unwell. He's developed a fever and diffuse erythematous rash over the last few days. So that's important. Fever and a diffuse rash. He has some systemic symptoms. His urine analysis is positive for blood and protein. So already we're kind of thinking of a certain way. Blood tests show raised creatinine and eosinophils. Okay. So his GP started him on a new medication 2 weeks ago, but he cannot remember the name or indication. So everything all together, he has blood and protein. We're probably thinking some sort of glomerular disease there, likely. Is it nephrotic or nephritic? We don't know the exact, protein or blood. But given the fact that he has eosinophils, his creatinine is increased, which indicates a reduced GFR. Remember, we said reduced GFR is key in nephritis. We're thinking of a glomerulonephritis. Or a possible tubular interstitial disease either. Okay, so it could be ATN or an interstitial disease. So that's a differential, but we see he has eosinophils. So eosinophils, as well as having a fever and a rash, that all indicates towards acute interstitial nephritis as a diagnosis. So which one of these drugs that he's currently on would we be happy to continue at present, given that we suspect that? So allopurinol, amoxicillin, diclofenac, omeprazole, prednisolone. So I can tell you the first four are big no-nos. They're all perpetrators of AIN. So prednisolone is a correct answer because it doesn't cause AIN, and actually it's one of the treatments for severe AIN. So that's it. Second last one. 51-year-old man with AKI. He's developed fluid overload. This is kind of a high yield one because of dialysis. So he has AKI, he has fluid overload, and you've gone to assess him, you've done an ABCDE. So his airway is fine, but he's a bit confused. His breathing's a bit up and he's on oxygen, and you heard bibasal creps. He's a bit tachycardic and he has a friction rub. So he's GCS 14 because he's confused, his temp is fine. So these are his ABG results. You can see he's acidotic. And I know that can only be caused by a high CO2 or a low bicarb. So which one is it? Bicarb is a little bit low and PCO2 is a little bit is normal. So it's a metabolic in nature. And then is there some respiratory compensation? So this could be a mixed picture because the respiratory hasn't compensated, or it could be just, initial disease. Anyway, so which one of these is an indication for urgent dialysis? So his urea is very high, his creatinine is very high, his lactate's okay. So his potassium of 6.3, which isn't mentioned here, a pH of 7.28, creatinine of 729, urea 53, or bibasal crackles. So to answer this, what we do is we go back to AEIOU. His pH isn't low enough, it's not less than 7.1. Potassium is 6.3, but we tried treating it. It's not very severe. 6.5 is sometimes a cutoff. Creatinine, you never acutely dialyze based on creatinine. Urea 53, maybe. Let's go back to it. Bibasal crackles. So we're talking about edema, but we don't know if it's refractory or not. I don't know if they've treated it. So the definite indication, other maybe relative, the definite indication is urea with symptoms. So you remember that uremia with complications like encephalopathy, which he has, and a uremic pericarditis, which it sounds like he has, is a definite indication for dialysis. And let's finish off here with the last one. So 57-year-old woman has become hypotensive tachycardic 2 hours after a lap partial gastrectomy for a tumor. So her blood classes are as follows, and what's the most likely diagnosis? This one I might get you guys to do just because it's the last one and it takes some calculation. So just take your time with it. You can see the acid-base disturbance on screen there, and you can answer what you think. This one's a bit of a tricky one, but we'll talk through it. Just you can try and answer it, whichever one you think is right, and we'll talk through it. So this one's bringing a little bit of respiratory medicine into it as well as renal. Okay, so let's just talk through it now. Thanks for everyone who did answer. So this lady's 2 hours post-op and she's becoming hypertensive and tachycardic. What do we see on the ABG? So we see that so there's two things to look on ABG. Obviously, you've had the respiratory lecture already. You can talk about respiratory failures, different types, and what we're talking about today is the acidosis versus alkalosis. So pH is low, so it's anacidosis, we know that. And again, let's go back. They can either be caused by too much CO2 or too little bicarb. So there is too much CO2 and the bicarb is normal. So this is a respiratory acidosis because of retention of CO2, okay? So already we know that when we spoke about our different causes for respiratory alkalosis and respiratory acidosis, we said it's either due to hypo or hyperventilation. So in this case, a respiratory acidosis likely is due to hypoventilation. But let's not taking it, we don't treat numbers, we treat patients. Okay, so I understand that if you look at the clinical scenario, it could definitely be any of these, and you'd be concerned for the other ones like PE, lung atelectasis, pulmonary edema. It could be any of them. Let's look a little bit at the respiratory point of view. So is it a type 1 respiratory failure or type 2? So first we look at the PO2. So it's low, so we know it's either one of the two. Okay, so type 1 respiratory failure is low oxygen with normal or low CO2. Type 2 respiratory failure, which means you're adequately breathing. Type 2 respiratory failure is when there's low oxygen but high CO2, so you're retaining. So that means that there's some sort of ventilatory problem. So those two things in conjunction indicate this is all a ventilation problem and due to hyperventilation. Okay. Why would someone like this hyperventilate post-op? A few different reasons. Number one, pain. If someone's just had surgery in their stomach, they won't want to take a deep breath. It'll cause pain everywhere. Number two, they are usually on loads of narcotics like opioids, and that can cause respiratory depression, which is probably what's going on here, given that she's hypotensive as well. And then the anesthetics as well, the anesthesia, she could be recovering from that still. Now, it could still be a PE, a pulmonary edema, or lung atelectasis, but you wouldn't really expect to see a high PCO2 with these. You'd only expect to see a low PO2. Now, late stage of pulmonary embolism, when you've been breathing so much that you become tired, then you can get this picture, but it's only been 2 hours, so unlikely. I think that's it. Take a deep breath. You made it through. That was a lot. An hour and a half, I think, total. So thanks to everyone for listening.